There are a number of points that have been made, but let's go back to human lives for a second. And Isabella, I wonder if you could give us a description of what cumulative disadvantage looks like in the communities that you work with in Nairobi, and how the disparities for older people affect those younger than them.
Is it on? Yeah. Thank you, Linda. So the first point to make is that, of course, when I spoke about the interregional disparities, I did not mention the fact that in sub-Saharan Africa too, there are major disparities between the rich and the poor in opportunities for health in later life. And the opportunities for health in later life are particularly constrained in some of the communities that we work with in urban slums in Nairobi. And the qualitative, in particular the qualitative work that we've done with older adults in these slum contexts have shown that their constrained opportunities for health manifest in their daily lives. First of all, in the sheer suffering, the sheer physical suffering of pain, for example, from musculoskeletal disease, that they are unable to treat because they don't have the resources to access health services. It's an element we often don't think about, but it's the sheer physical suffering of pain. The other is a constant stress, a stress linked to fear about an early death, a curtailed life because the resources are unavailable to access health care when needed, and a stress about, for many, about not being able to be there for the younger generations, in particular the grandchildren, for many of whom these older people are the main source of support, the main carers. And the impaired health of these grandparents means that they are not able to provide the care and the support that they think they ought to. So this too is a source of immense stress for the older population, which in turn, I guess, further undermines their physical health. So it's a vicious cycle.
So in some ways, what's implicit in there goes to the point that Harvey was making, that even while the older adults in the slum that you work in Nairobi are manifesting the consequences of cumulative disadvantage and current inability to access care and health, they are also a huge resource for in raising their grandchildren to a large degree. And while we don't have metrics for that economic productivity, it is essential for society. There are many metrics, Harvey, that we use. You mentioned years of life lost, certainly the old age dependency ratio, the concept of premature mortality as being the area where we uniquely should focus. All of these, as you laid out very elegantly, bias against embracing the full breadth of the human population and understanding both the rights and the values at every age. But there are other values in thinking about health for older adults, and Luis Miguel, we've talked a lot about the fact that health systems designed for older people actually are health systems that a world of non-communicable diseases could benefit from for every age. Can you elaborate on what a geriatric health system means?
Yes, absolutely. And in fact, we were able to develop an aging-friendly health system. It would be a system friendly for everyone when it focuses on building and preserving the intrinsic capacity, when it focuses on recognizing the relevance of functional ability in health, when it builds about the principles of equality and justice, and when it opens the possibility of access for every individual, disabled or not. Because in fact, at the end, what really matters from the perspective of aging is not age itself. We could say eventually that in terms of aging, age doesn't really matter. What matters is the intrinsic capacity of the individual, and it matters at any age. And what we need to develop in terms of disability, ease of access, and support would be useful for anyone of any age suffering of functional impairment or a diminished intrinsic capacity.
So you and I are both geriatricians, and there has been a tremendous set of accomplishments over the last 30 years in terms of the creation of geriatric medical systems, not so much on the geriatric public health system side, but the continuum of care for people with complex health problems, from hospital to clinic to community to home, very much matches much of what has been discussed already in this conference in terms of goals for task shifting, goals for utilizing an array of approaches that keep people healthy and functional and able to provide care in their own home for themselves as well as through other people. What do we need to do to think about prevention? So from a geriatric public health point of view, and this probably is to both you and to Isabella, we've talked about the prevention of premature mortality, and in fact, that is a start because we now know that we can not only save lives now, but we can invest in the future health of populations who will age, healthy or not. Does prevention work in older age?
Absolutely, and the focus of prevention in older age it must change as well, depending on the intrinsic capacity of the individual that we are addressing. In general, the same preventive measures as avoiding smoking, for example, will work, and there is evidence about it, but with people with an already compromised intrinsic capacity, it would be much more important to address the prevention of disability and the prevention of need for care. And this relies on the introduction of social support measures and on not only medical interventions. And that must broaden our scope and the scope of the practitioners to this, to the relevance of the social and economic determinants that we have to address as well if we want to be efficient, preventing what at the end is the real issue, which is old age dependence. Dependence resulting from disability or frailty as well.
Thank you. So two more questions, and then I'd like to invite the audience up to ask this wonderful group question. Harm?
Not a question, just a comment. The general understanding has been that if we increase longevity by a year or two, we're simply also increasing morbidity. And this has been the economist's nightmare that I mentioned before. I think this fundamental assumption is wrong, and it must be wrong logically, because the reason that mortality declines is that the syndrome of illness declines as a whole. And if that is true, then the symptomatology of illness, the debilitation of illness, is concurrent with the decrease in mortality, so that it is one pathway that combines the entire illness sequence, so that if we have fewer heart attacks, we probably have less severe heart disease altogether, and not more. And this has been a fundamental problem in our debates about illness vis-a-vis mortality and the compression of morbidity that you brought up.
Thank you. Yeah, Luis?
And very briefly, to build on this, there is the evidence that has been developed by Dana Goldman, the future elderly model, the projections that he has been able to build from the Health and Retirement Survey, showing exactly this idea and how the increase in longevity will not necessarily create a burden on the health system.
So I feel like I would be negligent if I didn't in the context of talking about health disparities and aging, talk about the issue of gender for 1 second. Because there have been many sessions already this morning and tomorrow about the global war on women. One of the things we haven't mentioned, of course, is that women live longer, and for every 80 men in the older population, there are 100 women. And so the experience of aging in the aggregate population is very much compounded by the cumulative adversities that women distinctly experience and the lack of social protections that they particularly experience in society. And at older age, at the same time, they are picking up the care of younger generations. So Isabella, before we turn to the audience, I wonder if you could help us wrap this up in the context of the Madrid Declaration from 2002, where that meeting said so importantly that development agendas had to put aging at the center or they would fail. Why does this matter? We often say, as was said this morning, we can't get to that yet. Is that true?
Well, the reality is that we have not got there. And the point that I made earlier was that although all societies have signed up to the Madrid Plan of Action and other plans of the same nature and in the same spirit, and still issues of older people have not been mainstreamed into economic and social development agendas. Some of the reasons have been articulated really well by Harvey. It all boils down to the primacy of looking at market productivity as an indicator of a person's value and importance and strategic relevance in development agendas. We might have an opportunity now in the SDGs, where SDG number 3, is it number 3? Yes, number 3, explicitly mentions the obligation to promote health and well-being for all at all ages. I think this is a better opportunity than we've had for a long time to ensure that, or to at least move in the right direction of governments looking at older age as a part of the mainstream development agenda. I think we have a role to play in helping that along. And perhaps when we turn to the audience, we can think about what is needed to that effect. But I think we have a better opportunity now than we ever had.
Thank you. So I'd like to invite people up to the microphone for questions, comments, or answers to Isabella's question. Because the issue of, well, I won't philosophize. The first question, please. Yes. Can you turn the microphone?
Yes, okay. Thank you for that, the panel. Kate Martin met me yesterday and said, your concern, the concern you raised last year conference, why we don't have this discussion on aging, why it wasn't in the last conference. You know, the concern has brought us to consider it and is in this conference. So I want you to be part of this. So I was so excited. So I've been sitting here and listening to all the discussions on aging, and it's exciting. So having said that, I want to thank you, Linda, for mentioning one thing, human rights. That just the consideration of human rights is actually an area that needs to, that can drive the care for the elderly. You can imagine how disappointed I was this morning when Jimmy, forgive me for saying that, actually when I raised the question, what is the global health community doing about the care of the elderly? And he said, well, it's probably not an area of attention. But this discussion has really proven that either it has supported it actually, that it's not an area that has gained a lot of attention, but it needs to get the attention that it deserves. And so I want to say something about what Louis said about if we're going to be saying that, or if people are saying that the elderlies do not necessarily contribute to economy, that's probably why the health resources are not skewed to them. You've given me an answer that I'm taking home. And that is one thing. If we're not providing health care for them because we feel they're not contributing so much to the economy, why are we doing so for the unemployed and the underemployed? You know, so it's actually a very important eye-opener. Then, you talked about that of aging in Africa, and I'm excited. It's as if my coming here, one important thing I came here to do is to meet you, Ma. I really have to meet you after this session. So, talking about the aging in Africa and the gap, there are a lot of things you mentioned. I can't express all of them, but one key thing is, I will still talk about it, and that is universal health coverage. Gaining opportunity in the national health insurance schemes of African countries. That's an area we could look into. Engage stakeholders to have more of our elderly persons into that program, because there are a lot of countries that have Medicare at their disposal. So elderly persons at such points can actually get health services. But in Africa, we don't have that opportunity, especially sub-Saharan Africa. So if we can leverage on that, it could actually go a long way. And also very important is when you talked about the gap in the workforce. I'm partnering with West African College of Nursing. I'm a nurse. My name is Amara Frances from Nigeria. All right, so I'm partnering with West African College of Nursing to train health workers in aging, to bring about the awareness. Is very, very low. So we organize this training every year. Students are free, and healthcare workers get to pay a token for that conference. And it trains health workers on aging and how to provide health care for the aging population. It creates that awareness. And also very important is the opportunity to bring community mobilization, to bring about education on healthy aging in communities and also across hospitals. So it's a lot that maybe we could talk more after this session, but I want to say thank you for this session. I'm really excited. Thank you.
Thank you so much for all those comments. Any comment from anyone? Harvey and Isabella?
Just a very quick comment, but a potent one, insofar as the older population not contributing to the economy. The older population represents the greatest users of health services. Health services are the fastest growing part of the economy. So it is the elderly who are largely supporting a great deal of our gross national product.
Yeah, if I can, just a few responses. The first is about human rights. You're very right to raise the importance of highlighting the human rights issue and health as a right for older people. But I would like to suggest that it's not enough. We have frameworks that enshrine the human rights of older people to health, including an African protocol on the rights of older persons. It's not enough. We need to make the economic argument. That's the first. In relation to that, and building on Harvey's point, all the evidence we have is that, at least in sub-Saharan Africa, older people play critical roles in the economy, for example, in smallholder agriculture, but they also play critical roles within families and communities, in child care, for example, and other roles, which are productive, perhaps not market productivity, but productive in other ways. So to say that they don't contribute is a fallacy. And then lastly, if you permit me, just on the universal health coverage, there are a number of countries that are trying to include older people in national health insurance schemes. So for example, Ghana or Kenya. That's an important step, but it speaks only to the issue of financial coverage. There is no attention, no debate about what the package of services has to be that is offered to older people. And the package of service that's available at the moment does not address the main needs that they have. So, thank you.
Thank you. We are just about out of time. I can take one more question, and then I apologize, but for the last one, please come up and join us afterwards. Yes.
I think it's on now. My name is Madeline Nagel. I'm the director of a WHO collaborating center at the Myers College of Nursing at NYU. And our mandate in that collaborating center is to build capacity among healthcare professionals to care for older adults, but also to promote healthy aging. And I see, and that's for all health professionals, not just nurses. But I see the two components of this issue, and I thank you very much for the panel, but it also jumps forth from your panel presentation as education and policy, and then education about policy and how to change policy and influence policy to better meet the needs of older adults. So nursing has incorporated geriatric care into undergraduate and master's programs throughout the United States. And I am wondering, and this is my question, how that's being paralleled in public health and in medicine and in psychology. What are we doing to build capacity? Because while we will not have enough healthcare professionals who are smart about geriatrics and geriatric nursing, we are going to have to use those people to educate others and to develop caregivers at the next level. So what's happening in other disciplines?
So I think that Isabella already addressed the dearth of geriatricians in Africa. I don't want to give that short shrift, but you gave us pretty compelling data of the absence of geriatrically trained physicians, at least. I can say in China, that China is investing hugely in the development of geriatric health professionals. Cuba has more geriatricians per person by far than the US has the opportunity to see for many years. So discrete countries are making very important investments. Many of the European countries have invested hugely in training of a geriatric workforce, and I say that broadly in terms of medicine, nursing, social work, et cetera. Do you want to speak to Latin America?
Yes, briefly. In fact, in Latin America, we have been working in the same direction, but recognizing that we will never have enough geriatricians, we have been developing as well an initiative to train primary care practitioners as well in the nursing professions, in social services, and the primary care physicians. And together with PAHO, with Pan American Health Organization, we have developed a training program, and we are now going to introduce the ICOPE protocol that has been developed at the WHO initiative for a strategy and action plan on aging, and test the feasibility and the impact of these interventions at the primary care level. We believe that we have to continue developing the specialty. In Mexico, we have 600 geriatricians for 120 million Mexicans. We are not enough, but we are working as well in the development of capacities, specifically within the primary care professionals.
So for the U.S., I used to be the chief of geriatric medicine at Johns Hopkins, and I can say from that point of view that while there are very well developed models, as you have, of the continuum of geriatric clinical care in the U.S. as a whole has resolutely resisted building a health professions workforce prepared to provide the care we need for a population of longer lives. And public health, quite frankly, in the U.S., and even at the WHO in the last 6 months, is pretty much nowhere. I understand that WHO just closed down its program on aging and human development, and while it's sustaining its mandatory retirement age of 62, the US has really starved its public health system over the recent years, which has precluded the development of community and population-based approaches for exactly what we need, investing in health for at every age and stage of life for future well-being, and that we desperately need to correct that. Thank you all so much for being here with us, and look forward to continuing the conversation.